Sovik sir, you can start now. We are live now. Thank you.
Yeah, thank you. Welcome to the expert crosstalk on impact reflection and very good evening. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to Emperor HF trial, does SGLT2 inhibitor can be considered as an important drug for HFrEF? For this, let me introduce today's speakers. Today's speakers are Dr. Anant Nigam and Dr. T. Nair. I am the moderator, Dr. Shavi. Dr. Anant Nigam is a director, Nigam Diabetes Center, Jaipur in India, and is also a fellow at Royal College of Physicians, Glasgow, and also a visiting fellow at Joslin Diabetes Center and Johns Hopkins University at Baltimore, USA. So Dr. Nigam has a career in diabetes span over 36 years and has been considered as one of the among India's foremost diabetes center. He has delivered invited lectures in several national and international podiums, especially in Johns Hopkins University School of Medicine in the US, and also is invited as the chair sessions of IDF and also the ADA Middle East Congress and Diabetes Technology at Bethesda, Maryland, USA. Also, he has been an evaluator of abstracts in ADS meeting and has been awarded several orations and also a founding member of World Foundation on Prevention Diabetes at Atlanta and on various committees in Indian Council of Medical Research for evaluation of project studies and creating consensus guidelines. And he has several publications in international journals and also contributed several chapters in several books and also an editorial board member of Diabetes and Metabolic Syndrome. And he has been chaired the organizing committee of National RDCSDI and Diabetes India International Conference. I welcome Dr. Anant in this expert webinar.
Thank you.
Our next speaker is Dr. T. Nair. Dr. T. Nair is a consultant cardiologist at PRS Hospital, Trivandrum. And Dr. T. Nair has several national and international publications in his credit and authored several books on medical book on medical statistics. He's also principal investigator of ADS international trials and has got a special interest in the areas of hypertension, heart failure, acute MI in young patients and antithrombotics. I welcome Dr. T. Nair in this expert web talk, and I'm handing the session to Dr. Anant to start with the presentation. Thank
you. Thank you, Dr. Shovik, for the kind introduction. I thank Lupin for this invitation to speak to you this evening on type 2 diabetes and cardiovascular disease. Well, this is a very complex and multifactorial relationship that diabetes enjoys with cardiovascular disease. And I'm sure all of you have had the chance to use SGLT2 inhibitors, and whatever data has arrived in the last 5 years, there is no doubt that it has ushered in absolutely a new paradigm in the therapy of type 2 diabetes and also type 2 diabetes and cardiovascular disease. These are my disclosures. Well, here is a patient whom I saw in 2020, early January. She's a 55-year-old.
We can't see your slides. We can't see your slides.
Pardon?
Sorry, please share.
We can't see your slides.
You can't see my slides. Okay.
No, please share the screen, sir.
No. Oh, I shared that. 1 minute. Okay, right. Sorry. So that's the first slide.
Yes, sir. Okay.
Yeah. So here is a 55-year-old university professor. She's got diabetes for 9 years, type 2 diabetes. Comorbid conditions are hypertension, coronary artery disease, and she had a PCI in June of 2019. She had seen a cardiologist about 5 months ago, and when she presented to me, she was short of breath on mild and moderate exertion for 3 weeks, swelling on feet for 2 weeks. Her current medications for diabetes included metformin, 3 milligram glimepiride per day, and sitagliptin. And of course, she had a lot of other medications for the cardiac problem: telmisartan, metoprolol, statins, aspirin, and spironolactone, probably because she also had a similar problem when she last saw her cardiologist. These are her physical examination findings: a BMI of 27, a blood pressure of 140. On examination, there were crepitations in both bases. Extremities showed edema of feet. The peripheral pulses were, of course, good. Her HbA1c had been hovering around 8.2 for the last 5 months. EGFR was 40. The NT-proBNP was 758. Hemoglobin was 12.3. And albumin creatinine was 326. ECG suggestive of old anteroseptal myocardial infarction, but no fresh ischemia. And the echo that we got done recently at that point of time when she presented showed a scar of old MI, reduced wall motion, left ventricular hypertrophy, and dilatation. And the ejection fraction was 38. So, well, it was clear that this was type 2 diabetes with atherosclerotic cardiovascular disease, heart failure, hypertension, and diabetic kidney disease. I'm sure all of us would agree that for this lady with comorbid conditions, one would like to keep the HbA1c between 7 to 7.5. Now, cardiovascular disease and type 2 diabetes present in several fashions. The risk of coronary artery disease increases 2 to 4 times, heart failure 2 to 5 times, and stroke 2 to 4 times again. 65% of deaths are due to cardiovascular disease, and about 75% hospitalizations are because of cardiovascular. So, as I mentioned, the relationship between cardiovascular disease and type 2 diabetes is complex and multifactorial. Diabetes is supposed to be a risk equivalent of heart disease. And it's like having a previous heart disease. So you see the blue boxes are people with diabetes, the red are no diabetes. And if you see the blue box, the first small one, it is diabetes but no MI, and look at his risk of a 7-year-old incidence of myocardial infarction is the same as a person who did not have diabetes but had already had a MI. Now, if this person with diabetes gets a MI, the risk increases to 45%. Both male and female patients have increased risk of myocardial infarction, stroke, and total mortality. The interesting aspect, though, is that this heightened risk of complications begins maybe years or decades before the clinical onset of type 2 diabetes. So macrovascular complications usually start way before, and so it's wrong to believe that when you got diabetes, you got a heart disease very, very early, but so the story has already begun very early. And this is the distribution or the initial presentation of cardiovascular disease in people with diabetes and no diabetes. You can see the bars there, which show very clearly that 50% of these people will have a heart failure. And so heart failure is usually a frequent, forgotten, and fatal complication of diabetes. It occurs more often than myocardial infarction or stroke. Even when it comes to hospitalization, the risk for heart failure hospitalization is much more than stroke, dysrhythmias, or acute coronary syndromes that are seen so frequently in people with type 2 diabetes. And similarly, diabetes increases the risk of hospitalization or death due to heart failure. You can see the dotted lines are people without diabetes, and the solid lines are people with diabetes, and both forms of heart failure, whether it is reduced ejection fraction or preserved ejection fraction, increase in people with diabetes. What happens if your HbA1c goes up by 1%? Your risk of heart failure increases by almost 8%. And these are several studies which have shown that if you decrease your HbA1c, you can reduce the risk of heart failure, hospitalization for heart failure. Now, let me touch another very important aspect of type 2 diabetes, and that is the association with kidney disease. And this kidney disease is then associated, this lower EGFR associated with increased risk of cardiovascular events and all-cause death. And you can see the bars up there. The CV events and death rates all increase as EGFR falls. And so this is called a disease multiplier. The interrelationship is rather complex, and both kidney disease and diabetes are major and independent risk factors for the development of heart failure. there is increased mortality, and a number of mechanisms, as are shown here, with salt and water retention, stiff and overfilled ventricles, renal injury, myocardial dysfunction, vascular stiffness are responsible for all these factors that you see. Now, let me just talk to you about the management of type 2 diabetes. Now, these are the therapies that have been available for almost 10 years. The DPP-4 inhibitors arrived in 2008. And before the arrival of DPP-4 inhibitors, before the first CVOT trials, we were looking at glycemic control, hypoglycemic risk, and weight. And this was also after the arrival of DPP-4 inhibitors. But then what happened? We started looking at CV risk reduction. Then when the saxagliptin came in, heart failure came to light. And then also with the arrival of saxagliptin, with the SABRE-TIMI trial, there was important notice of reduction of proteinuria with saxagliptin. And so renal functions in relation to the diabetes therapies came in fashion. And what happened when the SGLT2 inhibitors and the GLP-1s came in? Well, both of these, like the DPP-4 inhibitors, provided potent glycemic control with no risk of hypoglycemia, but importantly, both reduced weight, both reduced cardiovascular risk. Heart failure was predominantly reduced by SGLT2 inhibitors, and of course, renal function again very significantly improved with the SGLT2 inhibitors, but some important information also from the GLP-1s. But as far as the the GLP-1s are concerned, they were neutral for heart failure. So this is how the choice of type 2 diabetes therapies have changed. When a patient presents to me, I have to look at his CV risk reduction, his high heart failure risk, renal function, in addition to the other three factors that I mentioned. Now, these are the first CVOT trials that came in. The HFrEF was the first one, which had 100% patients with established cardiovascular disease. Canvas trial, 65% had cardiovascular disease, and DECLARE had 40%. You can see the primary and secondary endpoints, and you will notice that both HFrEF and Canvas, that is canagliflozin and empagliflozin, had a 14% reduction in the primary composite, that is MACE component, but the reduction of the secondary endpoints like the CV death and hospitalization for heart failure was very significant with the empagliflozin. Of course, it was present with canagliflozin, but was very, very little with dapagliflozin. And the MACE events were absolutely negligible. The benefit was negligible with dapagliflozin. Of course, they found that in people with early MI, dapagliflozin did show reduction of MACE. And this shows you similarly, and these trials were conducted with over 34,000 people, but importantly, most CV benefits were seen in patients with established cardiovascular disease. However, the benefit of for heart failure reduction was uniform across the three trials. The HFrEF showed very significant factors, and you can see the graphs between placebo and empagliflozin started separating within the first few months, and this was an eye-opener for scientists and observers all over the world, showing the importance of the use of SGLT2 inhibitors in patients with established cardiovascular disease. Mind you, people with HFrEF had all cardiovascular disease. So these were people with high-risk cardiovascular disease, and you can see the reduction of death from any cause, hospitalization for heart failure, reduction of death from cardiovascular cause, reduction of almost 38%. And therefore, you could divide the patients who use SGLT2 inhibitors according to the benefit that they gave, with patients with established cardiovascular disease, patients with cardiovascular disease or CV risk, patients with cardiovascular disease and chronic kidney disease, and patients with chronic kidney disease plus minus type 2 diabetes. And you can see here, empagliflozin almost fulfills the function of almost everything that you want, including MACE, hospitalization for heart failure, CV death, kidney disease, and all-cause mortality. Similarly, canagliflozin also gives you reduction of almost everything there, but EMP and the heart failure trials now with the DAPA-HF and Emperor reduced have significantly shown improvement in heart failure, and Dr. Tiny Nair is going to speak to you in detail about that. The kidney trials are also in, with the Credence as the first, which not only showed renal benefits, but also showed cardiovascular benefits in the form of reduction of hospitalization for heart failure. Now, what are the choice of anti-hyperglycemic therapies in people who have type 2 diabetes and heart failure? Well, sulfonylureas are supposed to be slightly increasing worsening the risk of heart failure. Metformin is absolutely safe if your eGFR is over 30. Glitazones are out. Amongst the DPP-4 inhibitors, saxagliptin has shown the risk of heart failure in people with diabetes, and insulin may sometimes exacerbate the risk of heart failure with by causing fluid retention. But look at the modern 3 therapies, and you will see here SGLT2 inhibitors in the bottom bar there have the best effect in reducing HFrEF, in reducing hospitalization for heart failure, much more than the GLP-1s, and of course the DPP-4 inhibitors were almost neutral, with saxagliptin increasing the risk for heart failure. Now, this is an excellent meta-analysis which showed the benefit of SGLT2 inhibitors according to risk factors. Now, if you see here, the reduction of MACE was only seen in people with atherosclerotic cardiovascular disease, but not in people who had only risk factors. However, the reduction of CV death and HFrEF were seen in both people with established cardiovascular disease and CV risk, or if they had heart failure or did not have heart failure, even then the risk of CV death and HFrEF was reduced. And the renal benefits were seen in both groups of patients with coronary artery disease or ASCVD and people who had multiple risk factors. So this is how you can really see that if your patient had a previous history of heart failure, he's definitely going to benefit as far as the reduction of CV death and HFrEF is concerned. But in people who just have risk factors, the MACE events will only decrease in people who have existing or established cardiovascular disease. Now, coming to the dedicated heart failure trials, the DAPA-HF was the first one to come, followed soon by the Emperor reduced. And look at the mirror image of the benefits that were seen in both these agents. A very interesting part of these agents was that this was also seen in people who did not have diabetes. So almost 25% reduction in CV death or HFrEF, and you can see it was absolutely the same in both DAPA-HF and Emperor reduced. The first hospitalization for heart failure, almost similar, 30%. Renal composite endpoint was much more in Emperor reduced, almost 50% reduction. And CV death was a little more in DAPA-HF, but probably because people in Emperor reduced were more sick people. More people on ARNI, and they were more, so probably the drug did not work in that more advanced heart failure. So they were more severe and sick people. But you will see here, both trials in people with diabetes and without diabetes have now shown very important results in reducing heart failure, especially in people with reduced ejection fraction. How does it happen? Well, probably the SGLT2 inhibitors improve ATP generation by changing the energy substrate from fatty acids to ketone oxidation. And that is how they decrease glycolysis, they increase glucose oxidation and decrease fatty acid oxidation, and thereby improve energy and give energy to the energy deprived heart after they have received. And this is a study by Subodh Verma, which was published in 2018 in relation to empagliflozin. Another very important aspect is the left ventricular mass index, which is a very strong and independent predictor of CV outcomes in people without CVD at baseline. And you can see here, for every 10 grams per meter square increase in LV mass index, the risk of events was increased by almost 33%. And you can see here the different tertiles. The red one showing that the survival will go down if you have increased left ventricular mass index. But what happens when you give empagliflozin? Here is a reduction in the LV mass, and this was the first confirmation of the mechanistic aspects of how SGLT2 inhibitors help patients with type 2 diabetes and cardiovascular disease with decreasing ventricular mass, left ventricular mass. Let me now speak to you for a minute about the renal trials which came in relation to the SGLT2 inhibitors, and the Credence trial was the first one to show that canagliflozin is superior to placebo in improving both renal aspects and also decreasing renal events and cardiovascular events in people with type 2 diabetes and established cardiovascular and chronic kidney disease. And you can see here, there was a composite reduction of end-stage renal disease, doubling of serum creatinine, renal or cardiovascular death to the tune of 30%. Similarly, data came in with the DAPA-CKD trial recently, and this also showed that it had salutary effects on renal function and mortality in people who had chronic kidney disease, irrespective of the diabetes status. The credence was only in people with type 2 diabetes, but DAPA-CKD was seen, the benefits were seen also in people without diabetes. Another very important highlight of the SGLT2 use in people with chronic kidney disease, even if you don't have diabetes. So here is, and similarly, the EMPA kidney disease, the EMPA kidney study is just awaiting its completion, and the results should be out very soon. I'm sure the results should be almost similar to what you've seen with the Credence and the DAPA-CKD trial. So Credence was therefore responsible for the change in the ADA standards, which were updated in 2019. And so they said for patients with type 2 diabetes and DKD, SGLT2 inhibitors could be used for even an eGFR of about 30, and that was the reason why FDA approved a new indication for canagliflozin to reduce the risk of ESKD, worsening of kidney function, CV death, HFrEF in adults with type 2 diabetes and DKD. Empagliflozin safety effects and tolerability data shows you very clearly that compared to placebo, there were hardly any adverse events. There were really no events related to discontinuation, and people with serious adverse events were also low or almost comparable to people on placebo when compared in these trials. And that is the relation, that is the reason why the ADA, ESD guidelines and a number of other guidelines like the European Society for Cardiology and the American College of Cardiology have all pushed up the use of SGLT2 inhibitors for the use of HF, especially HF, reduced ejection fraction, HFrEF, or CKD predominated patients. And if you see here that these will be the first agents to use, and if you can read the chart up there, you should be advised to use SGLT2 inhibitors or a GLP-1 with proven CVD benefits, irrespective, independently of the individualized HbA1c target. So if your patient is even at an HbA1c of 7.5 and presents to you with HFrEF, and he's on some other drug like a DPP-4 inhibitor or a SU, it is time to switch him on to a SGLT2 inhibitor and reduce the other agents to prevent hypoglycemia. So here is specific therapy independent of individualized targets, and you have to, it is advised now to consider to replace these therapies. And similarly, for patients with atherosclerotic cardiovascular disease, the first choice there is a GLP-1, but if the patient cannot tolerate or cannot afford a GLP-1, the SGLT2s with proven CVD benefits are advised. These are several mechanisms, both metabolic and non-metabolic, how the SGLT2 inhibitors provide CV and renal outcomes. And you can see here the metabolic effects, of course, all of you know, they decrease glucose, improve lipids, decrease body weight and visceral fat, decrease uric acid, increase glucagon, increase ketone body formation. And that's why they improve the cardio energetics, the muscle energy there, as I showed you. And here you can see here the non-metabolic effects are decrease in inflammation, decrease in oxidation, decrease in arterial stiffness, and by improving tubuloglommerular feedback, they improve what is called as dilated afferent arterioles, which are increased. They are dilated in the patients with type 2 diabetes, and SGLT2 inhibitors cause constriction and decrease intraglomerular pressure and decrease proteinuria. The upper panel shows you how diabetes-associated remodeling occurs, where you've got left ventricular hypertrophy, you've got increased cytokines and inflammation, you've got extracellular matrix remodeling, impaired cardiac metabolism, and apoptosis, and SGLT2s improve that. It is also now presumed and studied that they improve interstitial volume regulation more in relation to as compared to the intravascular volume as you compare it with the loop diuretics. And that is why how they're differentially regulated and improve heart failure. And so this leads us to the different labels that these molecules have now. And these are the FDA labels now available to reduce MACE events in adults with type 2 diabetes and established cardiovascular disease, to reduce the risk of kidney disease, worsening of kidney function. That's because of the credence I just showed you. And these labels have also been updated in India. The dapagliflozin has 2 labels for the treatment of HFrEF in patients with or without type 2 diabetes, making it the first time drug approved for heart failure. Also for CKD now, for use in patients with or without diabetes who have CKD to delay progression of renal failure and prevent CV events and renal disease. And the FDA label for empagliflozin is to reduce the risk of CV death. That's the only label, only CV death, that this molecule is the only molecule to have that label in people with type 2 diabetes and established cardiovascular disease. It has also been fast-tracked. It has also a fast-track designation for reduction of the risk of CV death and HFrEF in people with heart failure. An excellent review, an article by Verma et al. Showing you that you can really help people with type 2 diabetes. You can help their pump, reduce heart failure. With all the 3 molecules, you can control atherosclerosis, their pipes. That's only in people with established cardiovascular disease, especially empagliflozin with cardiovascular death, CANA and EMPA with MACE, and DAPA in people who have had prior MI, and of course, with their filters, that's renal disease, and you can use all of them. So that's an excellent, they cover all the pumps, the pipes, and the filter. So let's come back to that lady that I showed you. What do? We added an empagliflozin 25 milligrams, continued the sitagliptin, reduced her glimepiride from 3 milligram to 1 milligram, increased metformin to 2 grams, continued all cardiac medication, and continued spironolactone. In 3 weeks, she had significant symptomatic relief with breathlessness decreased and swelling on feet almost gone. At 10 weeks, when her cardiologist, we sent her back to the cardiologist for review, and he found the ejection fraction had improved to 41 and again increased further down the line. Of course, the patient showed benefits in both weight reduction and HbA1c. So this is how not only improving her metabolic status, you also improved her heart failure and improved her symptoms of breathlessness, which she was having on mild to moderate exertion. So who is an ideal candidate for SGLT2 inhibitors? Well, for glycemic control, you people who are uncontrolled on metformin monotherapy, have high HbA1c, who are on dual or triple therapy, not meeting glycemic goals, when you've got a compelling reason to decrease weight or promote weight loss or decrease the risk of hypoglycemia. And now with all this data that has come in, you should not miss prescribing SGLT2 inhibitors independently of individualized A1T targets in people who have HFrEF, have CKD, have ASCVD, if GLP-1s cannot be used or tolerated. And so is, do not miss prescribing in people without diabetes, in HFrEF, and CKD. So you've got people who do not have diabetes may also now start benefiting with chronic kidney disease and HFrEF. Well, still there is under-prescription of, and this is data just presented in 2020 to 2020, and you can see SGLT2s remain under-prescribed even in the United States, where only 9.3% people were prescribed SGLT2 inhibitors. This is my understanding, and the use of SGLT2 inhibitors after their arrival about 5 years ago, our numbers have gone up. They've shifted from SUs. Now we are using more combinations with DPP4 inhibitors and SGLT2s. We have a lot of patients who are now on GLP-1s and SGLT2 inhibitors, and we've got 3 papers we published in the American Diabetes Association Congress. And this is an excellent combination, again, for people who are very overweight, have established cardiovascular disease, have risk of heart failure. So friends, SGLT2 inhibitors, as I mentioned in my opening remarks, have really ushered in absolutely a new paradigm in the therapy of type 2 diabetes. They address the triple threat of cardiorenal syndromes. They benefit people with or without heart failure, with or without cardiovascular disease in some situations, but help all people with heart failure and renal disease. And the dedicated trials of heart failure have shown that they are useful also in people without type 2 diabetes. Thank you very much for your attention.
Thank you, Dr. Nigam. So I think we will finish both the topics since they're related and then take on the Q&A.
Yeah, I think that's good.
Okay, right. So I think we will continue to discuss on SGLT inhibitors and go on to the heart failure, which I talk about. Give me a moment's time by the time I share my screen. Is my screen visible and am I audible?
Yes.
Yeah, thank you. So I would be talking about heart failure and SGLT inhibitors, the Indian perspective 2020. Those are my disclosures. Now, last year, the Journal of American College of Cardiology, Dr. Javed Butler from University of Mississippi, published his data on the Pinnacle Registry of Heart Failure, which had about 11,000 patients, and looked into the clinical course of patients of worsening heart failure with, of course, reduced ejection fraction. So how did these patients behave in course of their heart failure? And what he found was really fascinating, and that is this. Number one, if you look at the left graph, you see that on the x-axis of these 11,000 patients, we have the survival probability. And in the y-axis, the x-axis, that's the y-axis, the x-axis, we have the time duration. At the end, you see 730 days, which means 2 years. At the end of 2 years, these patients of heart failure, you see 30% patients died. So 30% patients on follow-up of heart failure, reduced ejection fraction, died in 2 years' time. Not just that, what was even more surprising from this data set is this. If you looked into those after diagnosis of heart failure and looked into the first 30 days, what is the largest number of hospitalization for heart failure came within first 30 days of diagnosis. So 30% died in 2 years' time, bad enough. And in the first 30 days of diagnosis of heart failure, most patients got hospitalized, which again is a bad news. Now, last year, year before last, we published our own data of Trivandrum Heart Failure Registry, one of the registry data from India. And we were fortunate to be a part of it, all of us, from this city of Trivandrum, from where I live and work. And that got published in the American Heart Journal. And what we found was that in our data set, the 1 year mortality, not 2 years, was 30%. which means the Indian heart failure population fared much worse than the US counterpart. The second information which you need in course of time is about 60% of our patients had a previous acute coronary syndrome, ischemic heart disease. So 60% had a previous acute coronary syndrome and their heart failure was ischemic in origin, compared to a different data set from the Western world. But what was surprising from our Trivandrum heart failure registry is this. In this graph, you see the cumulative mortality of heart failure on the y-axis, mortality, while the x-axis, you see the follow-up time. Now that red line below is those patients who received guideline-directed medical therapy for heart failure, meaning that they received a beta blocker, an ACE inhibitor, and an mineralocorticoid receptor antagonist, MRA. So this triple therapy, those who got the triple therapy, look at their mortality versus the blue line who didn't get a guideline-directed medical therapy, suboptimal treatment. So patients who received suboptimal treatment had a 3 times higher mortality in India compared to those who got guideline-directed medical therapy. And this was hospitals where, these are all good hospitals in Trivandrum, where we pride ourselves that we give patients as far as possible guideline-directed medical therapy, right? They're all large hospitals. And you know what? Only 24% of our patients received guideline-directed medical therapy for heart failure. While those blue line, where the mortality was 3 times higher, that is 76% of our population did not get guideline-directed medical therapy. So I think first thing before we go into medical therapy at all, we should understand that we are not treating our patients well. And our heart failure patients have a far worse outcome than the Western population. And large number of our patients suffer from ischemic heart disease, which had an acute coronary syndrome in the past. Now, we all know the standard heart failure treatment. Just to revise ourselves, there's the ESC heart failure algorithm of treatment. All patients should receive after they are dehydrated, volume overload is taken away, they should receive an ACE inhibitor or maybe an ARB if they don't tolerate an ACE inhibitor, and a beta blocker. So ACE inhibitor, beta blocker are the basic, followed by an MRA, a mineralocorticoid receptor antagonist like an eplerenone or an aldactone. And of course, then if they still continue to be asymptomatic, they either graduate onto an ARNI or they go in for an ivabradine if their heart rate is faster, or we take them up for device therapy like the CRT. So basic triple therapy is ACE inhibitor, beta blocker, MRA. Right. Now, with that background, consider the DAPA-HF. We were all thrilled when DAPA-HF for the first time came in, simply because DAPA-HF showed us that there is benefit in heart failure. But many people don't realize this. So we will spend 5 minutes on this slide understanding why we are talking so much about SGLT inhibitors in heart failure. And this is very, very important. If we look into the progression of heart failure, like we look at signs and symptoms, let us start with the end part, the refractory heart failure, right? We know that once heart failure sets in, as we have seen in Indian data or the Western data, they progressively go down and finally what happens? They die. And that death occurs, like we said, 30% in 1 year in India, right? Now, apart from death, look at the graph, the red line. There are those dips and plateaus. So the heart failure patients suddenly worsen, get admitted to the intensive care unit with worsening heart failure. They get a large dose of diuretic, oxygen therapy. They become better and go home. Okay, they are fine, but they're slightly worse than before. So the course of the disease in heart failure, unlike any other disease, is punctuated by these gorges and plateaus. And these are heart failure hospitalization. So that is the reason why whenever you see a heart failure trial, we talk about death, CV death, plus heart failure hospitalization. Because the heart failure hospitalizations are not simple hospitalization like other disease. Okay, they are a huge stress to the person involved, huge stress to the family, and a huge economic burden to the entire health system. And as we have seen, in about 30 days' time, 50% patients come back with hospital admission. So any therapy that works for heart failure should not only reduce death, but also or reduce heart failure hospitalization. And that is why we look at this dual goal. And today we know that DAPA-HF and Emperor reduced. Empagliflozin and dapagliflozin very clearly showed that they attain this goal. This is what everyone knows. But think about it. Go one step behind. Why did the heart failure come at all? And we know that, for example, 60% of our patients had a previous acute coronary syndrome, right? And you have already heard Dr. Nigam talking about how SGLT inhibitors prevent MACE. They prevent development of a cardiac event, right? So Empire, Canvas, Declare, what did they basically show? That SGLT inhibitors tend to prevent an ischemic episode. So that is how SGLTs are beneficial. Now go one more step back. Understand that even before heart failure sets in, even before there's an acute coronary syndrome, these patients have multiple risk factors. And many of them, for example, you take type 2 diabetes, hypertension, obesity. SGLT inhibitors take care of multiple risk factors. For example, when we're talking about a cardiometabolic syndrome, SGLT inhibitors are one that take care of so many of the risk factors which go together. And the Swedish registry has very clearly showed us that if we take care of associated problems, for example, blood pressure, for example, LDL cholesterol, for example, microalbuminuria, and see that smoking is not there, we can actually kind of halt those MACE coming in a course of diabetes, right? So that is why SGLTs are important, because it has got an effect on almost every stage of progression of the natural history of heart failure. Now, the DAPA-HF, we will not spend time. We know that what was surprising was this. Yes, 25% reduction of primary event of heart failure hospitalization and cardiovascular death in diabetics and non-diabetic. Yes and no. See that box. Whether patient had diabetes or no diabetes, we had equal benefit by dapagliflozin. And with that came in the ESC presentation of Emperor Reduced. Now, Emperor Reduced got published in, of course, in New England Journal of Medicine. Basically, 3,730 patients, class 2 and 3 NYHA, ejection fraction less than 40% was the inclusion criteria, follow-up for 16 months. Primary endpoint was cardiovascular death and heart failure hospitalization. And the secondary endpoint was number of heart failure hospitalization and the progressive decline in GFR. They were the secondary endpoints. Now, we all know that these are patients who were extremely well treated. You know, they were extremely well treated. 70% patients had ACE or ARB, RAS inhibitors. 18% had ARMI, right? We had 95% patients on beta blockade and 70% on MRA. So they were very well treated with the gold standard medical therapy for heart failure. So they all received excellent therapy. Not just that, consider devices. 31% patients had an ICD and about 12% has a CRT. So they are one of the best treated population. And in that population, on addition of empagliflozin 10 milligrams, we see that there's a 25% reduction of cardiovascular death and heart failure hospitalization. That was the primary endpoint. And not just that, just like DAPA-HF, we saw that you can see the hazard ratio 0.75, p-value is 0.001. And like DAPA-HF, both diabetics and non-diabetics, both groups benefited equally. Okay, so this has transformed into basically heart failure drug. What about the first and recurrent hospitalization? We see that compared to the black line of placebo, meaning the standard, well-treated, gold standard GDMT for heart failure, versus the addition of empagliflozin gave us a 30% reduction of first and recurrent hospitalization. And that is obviously fascinating and good news to the cardiologists. Decline in GFR compared to the black line, which is placebo, the red dotted line of empagliflozin showed that in the long run of 124 weeks, which is 2 years, we see that there has been progressive prevention of fall of GFR, and that curve has kind of flattened with empagliflozin. Now, Dr. Milton Packer from Baylor University, Texas, brought out this beautiful meta-analysis of Emperor Reduced and DAPA-HF, and that came in Lancet. I think this is what we should take home understanding about SGLT inhibitors rather than trying to nitpick between emperor reduced and DAPA-HF. Basically, to me, they look in the same direction. For example, if you look at all-cause mortality, right, and you collect the data from emperor HF and DAPA, emperor reduced and DAPA-HF, you see there's a 13% reduction of all-cause mortality, and the directions are same. So that shows us that yes, the mortality reduction is there to a tune of 13%. What about cardiovascular death? Again, look at the data which covers emperor reduced and DAPA-HF. There is a 14% reduction of cardiovascular death. So the harshest two endpoints, strongest two endpoints, all-cause mortality and cardiovascular death, are reduced by SGLT inhibitors in heart failure, right? Consider ARNI. Today, the gold standard therapy is ARNI. We want to put patients today after transition trial in ARNI, even in the first hospitalization. So what about ARNI plus SGLT inhibitors? For example, in DAPA-HF, we had our doubts because the confidence interval of ARNI plus DAPA was very large. In fact, the right end of the confidence interval went to 1.13. But when we look into the collected data, we see that there is the emperor reduced data. We see there is a 32% reduction of the primary endpoints on use of ARNI plus SGLT inhibitors. And even those who did not receive ARNI, they benefited. Now, what about NYHA class? This is interesting and important. We see that both the trials showed that NYHA class 2 had a far more benefit than those beyond class 2, class 3, and class 4 were only very few, class 3, right? What does it mean to us, to you and me? We should start these drugs, which are very good drugs, early. Waiting to start SGLT inhibitor in a patient with terminal heart failure may not give you the benefit that you have seen in all these trials. So we should try to start them early in class 2 when the benefit is substantial. So the patient might be mildly symptomatic. He might say, I am fine with the drugs, say inhibitors, MRA, and beta blockers. But we should think that this is a drug that improves the hard endpoints of mortality and improves survival. So I should try to put them on as early as possible, even in class 2. Now, this is interesting. When we looked into, many of us were part of the the SGLT trials, including that ran in Asia. Now, if you look into the data set, what is most heartening is that unlike many other studies, the Asian population did absolutely well. In fact, one of the finest reduction of risk in the Asian populations as considered for heart failure. So this is a good news to it compared to North America or Latin America or Europe. Side effects, very few, and both Emperor and DAPA, it can be comparable to placebo, very few side effects. So safe drug and extremely effective. Now, last month in Lancet came a very interesting article by Muthaiya Vadiganathan, who is in Harvard. And this is a very interesting conceptual article. This is not a data, but concept article on collection of data, looked at the lifetime benefits, or what he calls as comprehensive disease-modifying therapies in heart failure. And by disease-modifying therapy, he considered ARNI, MRA, and SGLT inhibitors. So he's not talking about ACE inhibitor or ARB, not talking about beta blockade. So the new therapies that actually gives us survival benefit, ARNI, MRA, SGLT. What is their impact? Because we would always put the patients on beta blockade and ACE inhibitor or ARB. Now, it is interesting when you look at the analysis, addition of these three disease-modifying therapies, okay, reduce cardiovascular death by about 60%. The cardiovascular death plus heart failure hospitalization. Individually, cardiovascular death is reduced by about 50%, all-cause mortality by 50%. This theoretical proposition on the impact that we see, which means, let us say our patient of heart failure, the patient is fine, patient has no symptom, he's a beta blocker and ACE inhibitor. But think about it, if we put them on SGLT inhibitors, ARNI, and an MRA combination, we are reducing his cardiovascular death by 50%. Isn't that fascinating? So I think we should understand the data and try to put into practice from tomorrow. Because the patient of heart failure says, sir, I'm fine. Why you want me to take so much of costly medications, which are so costly? You know, doctor, I'm allergic to medicine. I don't tolerate strong medicine. But we should insist in the next 10 years' time, your chance of cardiovascular death comes down. The all-cause mortality comes down by 50%. So I should try my best as far as possible, as long as you tolerate it, to put you on an SGLT inhibitor, MRA and RNI if you have an heart failure with a significantly reduced ejection fraction. And even if you are in NYHA class 2, and that is the take-home point. Now, few points in Indian perspective before we end. One is that now echocardiogram machines are available in every small hospital. And physicians send for any dyspnea, effort intolerance for an echo. An echo often turns out that the patient has a little reduced ejection fraction, let's say 45, 43%, or maybe 38%. Or patient says, I'm fine. Little dilated LV. Patient is absolutely asymptomatic. Echo picked up a little LV dysfunction. Now, today we have the data, long-term data follow-up of heart failure trials of 15 years duration. Patients who were on enalapril for the last 15 years, we have found that those on therapy significantly did better. And we know that even asymptomatic LV dysfunction have a bad outcome in the long run. Meaning that whether my patient has symptoms or no symptoms, as long as I find there's an LV dysfunction in the echo, I presume that it is likely to progress. And one point of time when he becomes significantly symptomatic, my drugs may not work. So I should try to put him on drugs like SGLT inhibitors earlier. Second is post-CABG. You would have seen so many CABG patients coming after follow-up. What do they say? Doctor, I have no problem at all. So you ask them, why don't you come for follow-up? Sir, I had bypass surgery done. So the patient in India feels that once you have a bypass surgery done, every damn thing is cured. He has no problem at all, right? He can never have a problem. Sir, I had a bypass surgery done. You tell him that your A1C is high, your lipids are high. Sir, I had a bypass surgery. So many of these post-CABGs, when we do an echo, we would find that there is an LV dysfunction. Many often is part of the insult that they undergo or the previous ACS that they had. And these are patients who should be treated well, otherwise they often land up with cardiac failure. Post-MI LV dysfunction. Many of the patients who had an antival MI, on discharge, we find that there's an LV dysfunction, despite the point that they are fine, that angioplasty done. Don't miss out those patients, and these are patients who benefit with SGLT addition. And of course, patients with diabetes, obesity, hypertension, multiple comorbidities, and those who, of course, have the very classic cardiometabolic syndrome, where we know that the right in the center is a bad fat, and where you address the whole thing by an SGLT inhibitor. So the take-home message would be addition of SGLT inhibitors to the standard triple therapy of heart failure, meaning that ACE-ARB, beta blockers, MRA. To that, when you add an SGLT inhibitors, you gain by reducing cardiovascular death and heart failure hospitalization. Second, it slows progressive decline in GFR. Important because a large number of patients of heart failure have this slow decline of GFR and renal impairment. Third, all these drugs, the SGLT inhibitors, both the SGLT inhibitors, empagliflozin and dapagliflozin, DAPA-HF and EMPA reduced, have been tried on top of standard therapy on patients who are very well treated. And they are good in both diabetic as well as in non-diabetic. That is why that drug has come to us as a standard therapy for cardiac disease. And I believe that these drugs are likely to bring about a total change in the perspective they already brought around in the treatment of heart failure with reduced ejection fraction. And finally, this slide, one of my favorite slides, I always show in seminars of heart failure. Never let success go to your head, right? And never let failure get to your heart. Thank you for your time and attention. And me and Dr. Nigam, we are ready for Q&A.
Thank you, Dr. Tini and Dr. Anant, for your wonderful presentation. Okay, there is a question from the audience, Dr. Anant. Can I continue, sir?
Sure.
Yeah, please.
Fine. Yeah, the question is, after this Emperor HF trial, Do you think empagliflozin can be treated as part with the metformin?
Well, I showed you that there will be, this debate is now ongoing across the globe. Should metformin be the first line drug, or should therapies like SGLT2 inhibitors, the GLP-1s, take over in patients who have a different profile? So I would probably say, if the patient is able to tolerate metformin, I would continue metformin, but add this on time and take away the other therapy, as I mentioned. And the consensus also shows that irrespective of your individualized A1C target, you may be close to your target or you are already at target, and you have a profile which demands that you are on a GLP-1 or a SGLT2 inhibitor, take away the other molecule and put them on that molecule. So I would say I would use an empagliflozin in a patient with or without metformin. If you can't tolerate metformin, yes, that could be the first drug in people without with diabetes, without cardiac failure, with cardiac failure, or now even people without diabetes and lots of problems which Tiny just answered.
Yeah. Thank you.
Yeah, I fully agree.
Yes.
Just adding on that,
Yeah, please.
because this is something that there's a difference between individualistic approach and the epidemiological approach. For example, let's say a person who can afford all therapies today comes and shows that for the first time I am detected diabetic. I am detected diabetic, and a doctor, I have a very strong family history of diabetes. Many of my family members have died suddenly, and I have a little elevated lipids, I have a little blood pressure, and all that. And he is not on a therapy for diabetes. All of us would probably say, okay, you can straight away go on an SGLT inhibitor rather than starting on metformin, right? Despite the fact that all trials had piggybacked all these SGLTs on top of metformin, but we can always say that is there a data with metformin is milder and whatever it is. But when we are talking about a society, that's individual, right? If I develop diabetes tomorrow, most likely I'm going to eat empagliflozin. That is a different issue. But when we talk about an algorithm or a guideline for a society, metformin is cheap, metformin is safe, metformin is effective. And so it is likely to be accepted by the vast majority, right? And it has been proven over decades. And today we have trials running in UK for whether metformin can reduce cellular aging, right? So metformin is a good drug.
Yeah.
So when we are talking about an algorithm or a guideline for society, we would always say that metformin plus minus SGLT.
Especially if you've got type 2 diabetes, then metformin is going to do a lot of other good. Decrease hepatic glucose production, one of the most important agents to decrease hepatic glucose production and get your fastings back to normal. And so many other metabolic benefits that it has, which the UKPDS very clearly showed.
Yeah, absolutely. Absolutely.
The next question for Dr. Tini. Can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
See here, yeah, this is interesting. We should understand that when we see the collated data, the meta-analysis of EMPA-REG, Canvas, and Declare, what do we see? See, it is not trying to nitty-gritty or pick between one and the other. Okay, obviously there's a difference between, because CV Veritas trial has shown that empagliflozin is heart failure is beneficial, but MACE it is not effective. But if you take these three, the pattern is like this, because Declare CV had 40% CV cardiac patients, Canvas had 60% CV patients, and EMPA-REG had 100% CV patients. So they are obviously different. But what do we totally learn? If we give a patient with multiple risk factors and SGLT inhibitors, they are very good, right? Like we saw in the CVOT trial, they don't worsen cardiac outcomes. Okay, but the benefit obviously is going to be much lesser. Yeah, it's a good anti-diabetic drug, and you see that diamond goes slightly onto the left, meaning that there's a benefit, but not a statistically significant benefit. But on the other hand, if you use it in a patient who already had established CVD or an extremely high risk, obviously we are going to get a significant benefit, like what we saw in EMPA-REG, right? So it isn't a question of gradient. But today, if a patient can afford, and already patient has metformin, he has multiple risk factors, yes, SGLT inhibitors are a quite early choice, which was not there a couple of years back.
And that's exactly what I showed in that meta-analysis by Zellinger. You get the MACE benefits if you have existing heart disease. You may not get that benefit if you just have CV risk factors. But the benefit for CV death and HFrEF are present irrespective of whether you have a risk factor or established cardiovascular disease, if you have a heart failure or had no heart failure history, and the renal benefits are also seen in both groups. So they're excellent agents working absolutely in almost everything. But if you specifically want the MACE events, then of course, they work better with people who existing or established cardiovascular disease.
Thank you.
And as cardiologists, since we see a lot of patients of heart failure, the beauty of SGLT inhibitors are that they are inbuilt diuretics, right?
Yeah.
They reduce tissue edema. Yeah. So the beauty of it is that unlike other things, see, all these years we had been pumping a huge amount of Lasix to patients who come with heart failure. Okay, and they feel better because they get dehydrated. That feeling of well-being kicks in far later in ACE inhibitor or a beta blockade. Okay, but with SGLT inhibitors, the moment you start, the next very review, patient tells the doctor, sir, I'm feeling better. I can walk more. My edema has gone away. My lungs are clearer, because the diuretic effect kicks in and he gets dehydrated. So, in all the studies with both DAPA and EMPA, you see that the KCCQ, the Kansas City scores are all good. So not just patient improves, they would come and tell you, doctor, I'm feeling better. So despite this drug being costly, they will not stop it. That's it.
And tell me, the beauty is that they don't destroy or they don't take away the electrolytes. They are fine with the electrolyte. The electrolyte imbalance doesn't occur, which occurs with the loop diuretics.
True. In fact, whenever we start ARNI, for example, in heart failure, we are always bothered about potassium change. We are bothered about creatinine. So today, we are far more getting, an easy way out is to first add an SGLT inhibitor. And, many often for our postgraduates, we show a slide showing that there's a new heart failure drug and 25% reduction of primary endpoint. What is this drug? Everybody in cardiology will say ARNI. Will say, no, it's not ARNI, it's SGLT inhibitor. They look identical. And if you see Paradigm, HF trial, and maybe DAPA HF or our Emperor reduce, their inclusion criteria are almost similar. And their patients who were treated in the placebo arm were similar, right? 95% beta blockade, 80% ACE inhibitor. So they're so well treated. Absolutely. So I think we are going to see a time when we are going to see a combination of ARNI, MRA, and SGLT inhibitors clubbed on to almost every patient of heart failure who tolerates it.
Like you said, that they start working from the first dose. And when you see our glycemic effect, you give them this and their insulin doses will start falling the next day. If you have not reduced their sulfonylurea doses, they might get hypoglycemia. So the beauty with these drugs is that they start, even their metabolic effects for diabetologists is so good that you can start seeing the effects from the first dose and not wait for drugs to work.
And it's very funny, if you look at it that way. ARNI came in, and then the Lancet trial showed that ARNI improves HbA1c.
Yeah.
Okay, so a heart failure drug suddenly showed that it reduces HbA1c, your dose for insulin need comes down. And then we have a diabetic drug, dapagliflozin and empagliflozin, that showed that it reduces heart failure.
Yes.
So, it's so very funny that, we found the benefits of these drugs in such a interesting way.
Yeah. Dr. Tini and Dr. Yeah, thank you very much. There is no more questions. So we're running out of time. So can we conclude?
Okay. Thank you.
Thank you, Dr. Anant, Dr. Tini. On behalf of Lupin, we thank you for your excellent presentation and sharing your valuable experience. And we'll see in the future meetings. Thank you very much.
Thank you.
Thank you. Bye.
Thank you, Dr. Nigam. Bye. See you sometimes.
Thank you.
Bye. Yeah, sure.
Thank you.